I have a 29-year-old Caucasian female who presents to the clinic today with a chief complaint of my sleep medicine is causing headaches. Um, the patient states that the headaches begin when she started taking trazodone that was prescribed to her 2 months ago for insomnia. The patient describes the headache as a constant dull pain in the frontal lobe that radiates behind her head and down into her neck. The patient states she has not taken trazodone for 2 days and is only able to sleep 2 to 3 hours at a time when she doesn't take her trazodone. And she reports extreme drowsiness at work during the daytime that causes her to get sleepy at work. She's requesting different sleep medication. The headaches did stop when she stopped taking trazodone. The differential diagnosis for this would be primary insomnia, anxiety, and depression, or acute bacterial rhinosinusitis. The patient has a past medical history of attention deficit hyperactivity disorder. She also takes amphetamine, dextroamphetamine, 10 milligrams, POBID, twice a day, 10 milligrams in the morning, 10 milligrams at night for this. She denies anxiety or depression. She has no pertinent family or surgical history. Social history, she does exercise some. She walks 3 times a week for 30 minutes occasionally. Some weeks she does, some weeks she doesn't. She denies tobacco use. She's not a smoker. She denies smokeless tobacco of any kind. She denies alcohol use and denies drug use. She has seasonal allergies that she takes cetirizine for 10 milligrams daily as needed. And she has an allergy to penicillin that she has severe allergic reaction of anaphylaxis to. Review of systems. She denies fever, denies weight change, no weight gain or weight loss, no night sweats. She admits headaches, denies dizziness. She denies pain or ear drainage in her ears. She endorses itchy red eyes. She's currently having seasonal allergies. She denies runny or stuffy nose. She denies sore throat or trouble swallowing, but she does endorse sneezing. She denies shortness of breath, cough, no history of respiratory infections. She denies heart palpitations or chest pain or peripheral edema. Psych, she denies depression or anxiety or suicidal ideation, but she does endorse insomnia. Her vital signs are stable. Her blood pressure was 117/68. Her heart rate was 66. Her respiratory rate was 16, so she was stable. Upon physical exam, she was a fidgety 29-year-old Caucasian female, sitting upright, alert, and oriented ×3. Had no frontal or maxillary tenderness on palpation, so that ruled out bacterial sinusitis to me. Her ears, her auditory canals were without erythema or drainage bilaterally. Her tympanic membranes were pearly gray bilaterally. Her eyes were red bilaterally. There was no swelling. Her nose, there were no nasal polyps. Her membranes and mucosa was pink and moist. No purulent drainage. And that also helped to rule out bacterial rhinosinusitis. Her mouth and throat, posterior pharynx were without erythema or exudates. Neck, I did a neck exam of her thyroid just in case. Her thyroid gland was midline with no edema noted. There were no nodules palpated. If that had been the case, I would have done further tests. I would have examined this and explored this further as far as, a differential diagnosis of hyperthyroidism and would have done a TSH on her. but she had no edema noted, no nodules palpated, and had no other signs and symptoms of hyperthyroidism. Cardiovascularly, there were no murmurs or gallops. She had regular rate and rhythm. S1 and S2 were noted. Respirations cleared auscultation bilaterally. Respirations were even and unlabored. So there were no diagnostic tests performed for this patient. My assessment and plan for this patient, my diagnosis is primary insomnia. My plan was to stop trazodone. I think that's what was causing her headaches. I was to stop trazodone HCl 50 milligrams. I was going to start esopiclone, which is Lunesta, 2 milligram tabs, 1 tab PO before bedtime daily. I also was going to stop the Adderall 10 milligrams BID. I feel like that was also contributing to the patient's insomnia. And start Adderall 20 milligrams extended release 1 time daily in the morning. I think that would be a better option for her. And to reduce her screen time and practice sleep hygiene, reduce screen time from phones and computers at least 1 hour before bed. Maintain a consistent sleep schedule. Go to bed and wake up at the same time every day. That's a great routine to get into. Also, avoid large meals and caffeine. I know she says she did not drink alcohol, but if she were to start, to avoid that close to bedtime. And follow up with me with a provider appointment in 3 months unless she had any concerns, and then to call the clinic and we can see her sooner than that if she continued to have headaches, even after stopping the trazodone and starting the esopiclone as a substitute for trazodone. Also, my health promotion for her would be at 29 years old to recommend cervical cancer screening per U.S. Preventative Screening Task Force.